Hi everyone, myself Prabhakar, Associate Professor, Department of Pharmacology. Today we'll discuss about the leukotrienes. So first, let us discuss about the leukotrienes. Leukotrienes are biologically active lipid mediators which are derived from the cell membrane phospholipids formed from arachidonic acid via 5-lipoxygenase pathway reference from the prostaglandins. Synthesized from the mast cells, eosinophils, basophils, and macrophages, plays a crucial role on inflammatory and allergic responses, especially in respiratory disorders, like known as the slow reacting substances of anaphylaxis. So it is commonly called as SRSA. So this is the leukotrienes. We have to know about the source. Source is nothing but the 5-lipoxygenase pathway it is being synthesized from. So let us discuss about the biosynthesis of leukotrienes. So cell membrane phospholipids release arachidonic acid via phospholipase A2, and then arachidonic acid is converted to the 5-lipoxygenase into LTA4, that is unstable intermediate, and further LTA4 is further metabolized into LTB4 and LTC4, further converted to LTD4 and E4, and LTC4D4E4 are called as cysteinial leukotrienes, and these mediators are released during the allergic and inflammatory conditions. So these are called as leukotrienes. So generally you have to remember. So leukotrienes are just synthesized from the arachidonic acid pathway with the help of lipoxygenase pathway. Right? So similarly, we have another one inflammatory mediator, that is prostaglandin, which has been synthesized from the COX pathway. This is lipoxygenase pathway, that is cyclooxygenase pathway. We should not confuse both. Next, we have the biological functions of B4. So, chemotactic agents for neutrophils enhances the leukocyte adhesion and activation, the functions of LTB4. So, what does C4, D4, and E4 does is cause a prolonged bronchoconstriction, increase vascular permeability, leading to edema, stimulate the mucus production in airways. Overall, leukotrienes contribute significantly to the airway inflammation and hyperresponsiveness. So role in disease conditions. What are the role in the disease conditions? Nothing but the central role in bronchial asthma pathogenesis, involved in allergic rhinitis causing nasal congestion as well as inflammation, contribute to the anaphylaxis and hypersensitivity reactions, and may lead to the airway narrowing and increased mucus production, recruitment of inflammatory cells. So these are associated with the chronic inflammatory disorders of the respiratory tract. So what are the classification of leukotrienes? So to combat the leukotriene effects, we have the set of drugs which have been classified as a leukotriene receptor antagonist. As we know, they are cis LT1 receptor antagonists. So the drugs are montelukast, jafilukast, pranlukast, verlukast, iralucast, obilukast. So mechanism is to anyway to block the cysteal receptors, inhibit the formation of LTC4, D4, and E4. So all the mechanisms are almost similar. Pranlukast, verlukast, and elacast, wabilukast, both all the drugs having the similar mechanism, that is blocking the cis LT1 receptor blockade. So next we have the leukotriene synthesis inhibitor. So we have 5-lipoxygenase inhibitors, diluton, artilton, cetilton. Okay, so these drugs blocks the 5-lipoxygenase pathway and the formation of all leukotrienes. Artilton directly blocks the 5-lipoxygenase inhibitors, and cetilton is selective 5-lipoxygenase inhibitors. So next we have the leukotriene antagonist, uh, majorly used leukotriene antagonist. So uses of leukotriene antagonist we are seeing in this table. So first one is the chronic bronchial asthma. We have the drugs like montelukast, roflumilast, and diluton, and these are used as a prophylaxis and maintenance therapy. Reduce the airway inflammation and prevent the exacerbations. Exercise-induced bronchospasm. We have the montelukast, prevention before exercise, and taken prior to the physical activity. And allergic rhinitis, we have montelukast, which provides a symptomatic relief. reduces the nasal congestion, sneezing, and rhinorrhea. After in induced asthma, we have drugs like montelukast and jafelukast. These are the drug of choice and blocks the leukotriene mediated bronchoconstriction. Add-on therapy in asthma, we have montelukast and jafelukast, and in pediatric asthma, we have montelukast. COPD, we have gelatin, and atopic conditions, we have the montelukast. So for this, from this, we can easily understand that montelukast and jafelukast are both are the drug of choices for the major airway disorders. Like for adjunct therapy, supportive role, and they are useful for the symptomatic reliefs and the prevention before exercise. So all are the uses of leukotriene antagonist. So next we have the adverse drug reactions to the leukotriene antagonist. So montelukast is considered to be drug of choice, which is having the common areas like headache, abdominal pain, and fatigue, and serious areas like neuropsychiatric effects, anxiety, depression, and sleep disturbances. It may induce more sleep, and special precautions, we have to monitor mood or behavioral changes while administering the montelukast. And for Zophilukast, we have the similar kind of areas like headache, nausea, and GE upset. I have the hepatotoxicity, very rare, hypersensitivity reactions, and we have to monitor the liver function test. Zilitan, we have the areas like dyspepsia, headache, and nausea. Significant hepatotoxicity in elevated enzymes. So regular LFT monitoring is required. So effects are GI disturbances and where shed stress syndrome, eosinophilic vasculitis. So these are the serious areas of Gilita. Okay. So these are all the uses and adverse drug reactions of leukotriene antagonist. We have to remember. Okay. Thank you all.